Good afternoon, everybody. It's time to get started. I'm Dr. Ari Christopidis. I am the director and founder of the Orthodox Christian Counseling Institute in Chicago, and I'm pleased to present the speakers this afternoon. I've been given strict guidelines on what I'm supposed to say and how I'm supposed to say it, so bear with me here. So this afternoon, I'm looking forward to hearing from Dr. Stephen John Harris, who is from, no, I'm getting mixed up here with the locations between Newport Beach, California. Thank you. Thank you so much. And also with him is Father Paul Schellbach, who has his MDiv from St. Vladimir Seminary. And he's been a priest for 26 years, LCSW for 12 years, and has a mission church in North Carolina. And what they're going to be speaking on is the interactive care between priest and psychotherapist of the so-called dissociative identity disorder, some preliminary remarks. So a little bit about the background here. For the life of the parishioner who has experienced severe and debilitating trauma resulting in what was forenamed multiple personality disorder, there are many spiritual and psychological realities that demand important attention towards healing. The presentation will consider the dialogue between the theological and psychological realities, including areas of overlap between the two domains. So instead of talking more about that, I will let them speak to it. I'd like to welcome Dr. Stephen John Harris.
Thank you, and thank you very much for coming. I hope that this is more than just, my intention is that this will be more than, I hope you won't be disappointed, but just answers, but that we'll be able to have a discussion about these topics. This is a continuation of a presentation at O'Camper last year in Phoenix, in which someone who's here, Father Isaac Skidmore, and I discussed the dialogue between theology and psychology, and are they compatible? You know, we want them to be compatible. I think most of us do, but how are they, or how can they work together? And I thought I would take a bit of a background and case presentation to tease out some of those challenges. And so I really hope we can engage you into a discussion about this, because I think it's kind of not worth taking for granted, but kind of have an evolving paradigm about how we work together. They really are different. For one, they're ontologies. The ontology of the Orthodox Christian is grounded in the hypostasis in God and Christ. The ontology of psychotherapy is the human subject, and so that's so individual, and the other is so supported by the divinity. And so I think there's some important intersections for them, but there's some differences. Let's see. So, okay, ready or not, here I come. I'm lowering the bar a little bit for myself here, and maybe you too, so I can ease into this. Okay. So let's see. In considering the dialogue here between spiritual and psychological, or we could also say theological is probably more accurate, the distinctions in working with different ways of seeing the problem of a severely traumatized individual. That could have been another name for this. Instead of dissociative identity disorder, would have been, severely traumatized person. In my opinion, I think that a lot of attention needs to be paid by both priest or monastic spiritual father and therapist in a case like this. Each discipline can and should make their unique contribution to help. And after presenting a brief overview of trauma and the development of DID through the pathway of pretty severe PTSD, post-traumatic stress disorder, I'm going to present a brief hybrid case that will illustrate some of these key points and attempt to have that be what a starting point for us to look at the dialogue between the disciplines. Let's see. And hopefully an interactive framework that I'd like to see. Maybe it's kind of grandiose, but like to see that we're all at the beginning phases of talking about what that paradigm might look like, or at least in a working model kind of way. So let's see. So here's our objectives. Number one, develop an understanding of trauma and dissociation. For some of you, this may be quite a review. You might have heard a lot of this, but I'd like to bring us all into the same place if you have different background and so forth, so we can have that also not just because of what you already know, but as the lens we're all kind of starting with. And to discuss the important roles of priest and therapist, and then, as mentioned, begin the dialogue for different levels of which might feel crucial in terms of helping these people in their parish and functioning in their daily lives. All right. So a brief introduction to trauma and dissociation. One more remark besides the idea that this might be basic or something you've already heard before is also if there are things here that you'd like to take notes from or something like that, I'm glad to send you the slides. They're also being recorded on Ancient Faith, so you can get them there. But maybe you could sit back and enjoy the presentation, and because a few of the slides have lengthy things, and I'd like you to be able to digest it. And I'll send you these. You give me your email address at the end. I'll be glad to send you the slides kind of as a working notes or something. Okay. So persons successfully recover from everyday trauma and return to normal functioning all the time. Each of us, it's rare to find someone who hasn't had some kind of trauma in their life that they've recovered from. Successful recovery of trauma involves a combination of factors for most people, including how mild the trauma is, which in the field sometimes we call little t trauma, adequate emotional support in their lives, a biological disposition that allows for it to not be too overwhelming, the capacity biologically, and the provision of security and protection, and also, for many people, people like ourselves, the individual's faith and the support that goes with that. So, however, with severe and overwhelming experiences, especially when sustained, as well as an absence of some of the important ingredients here, things can become more difficult. And so things become overwhelming, and the mind has remarkable ways of surviving when it is met with something that is greater than what Dan Siegel calls the window of tolerance. It's too much. And yet the mind has an incredible way of surviving that, but at the same time, pushing it out of consciousness, what was too much to bear. And we call this in trauma theory dissociation. It's a little bit different than repression, where something is kind of unconsciously forgotten. It's sort of there, but pushed aside. Okay. So we all dissociate, again, but it's a matter of degree. The separation of emotional states can be necessary, but when it becomes chronic, a person becomes unable to access different parts of their mind and become unable to do what Philip Bromberg calls standing in the spaces between different parts of experiences and emotions. More serious when this happens, and they can't, I'll illustrate standing in the spaces in a few moments, but when they can't sort of move between different feelings, different states of mind, different thoughts, very fluidly, and things just get pushed away, this is part of what we call something that becomes more pathological and difficult, makes it difficult to function. On the other hand, in one way, it's a relief that we can do that we can separate parts of our mind, it would be overwhelming to experience everything at once. So we need normal dissociation. Dissociation can sound pathological, but it's actually part of healthy functioning, to be able to move from one thing to another. So the mind is marvelously made. Without getting too technical, a metaphor is that we can manage our minds like the way we wear different hats, the different roles we play, mother, priest, professional, friend, neighbor, and so on. And although these can run together. At the emotional level, the more fluidly and deliberately we can move among these, the more adapted we can be to the demands of life. The ability to move fluidly between different ways of coping, feeling, and relating, and so on, we might say, is healthy dissociation. Okay? And as we might also say with that, reassociating when necessary, bringing back something that was dissociated back for use when you need it. What concerns us here, though, for this talk, though, is pathological dissociation, on our way to discussing what is now called dissociative identity disorder. Healthy dissociation helps us cope with healthy hiccups of painful and stressful events, enabling us to return to normal functioning. But when someone cannot return to normal functioning, again, it's a lot of information, but we'll be going over this, and we'll be glad to give you this information later. When someone can't return to normal functioning, traumatology and neuroscience research has found that it points to something within the individual that remains unlived. It's not been experienced. It was too much to be experienced, so it was pushed away. It's part of experience that one has not lived, and the person is often unaware of this because the mind has actively, consciously or unconsciously, kicked the can down the road because of what is called a fear of breakdown. So when I say unconsciously, there's almost like a gut reaction, like, it just shuts off. It's not like the person deliberately can push it away. So fear of breakdown is like, if I do experience this, I'll fall apart. Okay, and I say kick the can down the road for an important reason. When we move forward in life, after the unlived portion remains, new experiences that fall into the category of that perceived threat or feel out of control or are overwhelming, they may not be just like the traumatic event, but they emotionally carry that overwhelm or something that might remind them. The person vigilantly detects them and perceives them as presenting themselves or lurking around the corner in brand new events. And so what should have been a memory but is unfinished is sort of projected into new things. And so sometimes people think that certain therapies like psychoanalysis focus too much on the past, and they could be right, but what we're really concerned here is how the past is intruding itself on the present and the future. It's unfinished, so it keeps getting kicked down the road and interfering. It is at this point that the unlived portion of the mind seems to shut down new experiences. When trauma is more severe, is ongoing, and the environment makes it difficult or intolerable to be present and receive support for recovery, the more likely dissociation will persist and become chronic. This can progress into post-traumatic stress disorder, and when post-traumatic stress disorder worsens, it may become severe enough to become dissociative identity disorder, where you have separate parts of the person, separate states of mind that are cut off from each other in a rather arbitrary, and in this fashion, the person becomes unable to manage their overwhelm when in some other state of mind will take over, frequently without any awareness on the person's part. When this quote-unquote taking over occurs and becomes ongoing and exhibits itself with the discrete states of mind, meaning the person has lost awareness while something else inside, another part of them, another ego state perhaps, or mood, or, we have different names for this, but This is what we call dissociative identity disorder. Marked, I don't have this in my paper here, but marked so often by when something else, sort of another part of them kind of took over and they weren't aware of it, there's a loss of time. It's almost like they didn't know what had happened. Because the trauma hasn't been lived or processed, many new life experiences are not integrated into a coherent narrative within the person's life. Outwardly, they may appear to be somewhat bland or even somewhat normal, while at the same time they're not able to put together and adapt to their experiences effectively. In place of a coherent narrative is a complex inner system that dictates arbitrary responses to different circumstances. For instance, an individual can suddenly become appeasing when feeling threatened by someone, or may abruptly get angry and attacking at another instance when perceiving threats or violation. Often the person feels ashamed of not being able to control these responses and behaviors because they don't seem to feel like they chose that. It's just something just surges, so to speak, takes over. According to the sequential model of dissociation, learning how these parts can work explain how this survival system works, and in my experience can assist with the healing process. Further understanding of the function of the divisions and the parts, such as protector, angry, reasoning, supportive, and so on, may help understand further the purpose of dissociation on the way to possible integration. The overall perspective is a view of how the mind dissociated in order to escape when there was no escape, to use Frank Putnam's words. The truth of the trauma became too much, and it appears as if, as a result of being unable to suffer, its goal is to not exist or to be. The truth has no mental space. Without a context or a relationship that creates space for what has been both unbearable and unspeakable, the emotional truth cannot be allowed. A separate space is then created for what that pain that has not existed before. Chronic dissociation can work to prevent the unconscious fear of breakdown. Several implications are involved, and I'll name a few. The prevention of the unthinkable, protection against disintegration anxiety of falling apart, and protection against annihilation of personal spirit. These are all works that will be referenced in the paper later that you can get from me if you want. And I added overall protection from the loss of self or ability to manage life. I want to briefly mention that some have questioned how DID is different from schizophrenia because both can hear voices. And so some researchers have suggested that the difference is that in schizophrenia, the person is unable to dissociate. They just, unravel, okay? They go all over the place. They fall apart. In DID, from this perspective, it's more of a compromise, a kind of division without completely falling apart. The person moves on through life, but they hold on. They also are divided inside, and it changes from scene to scene or moment to moment. This matter has not been resolved and remains subject to further investigation. By this matter, I mean whether that's a true difference between schizophrenia and dissociative identity disorder. The cost of this survival, this sort of dividing inside, can be great. Depression, rigid coping defenses, and a host of other struggles can result. And for the purpose of our discussion, the person may become very vulnerable to spiritual problems in what some people have called evil influences. They may improve with prayer, but their emotional dysregulation continues. In the hybrid case that follows, many features of both psychological and spiritual concerns will be presented to illustrate our task for this dialogue. The following case is not a real case in that it does not represent the facts of any one case, but is an amalgamation of case material of the details of many cases gathered by me over time. Any similarity is coincidental. This is like the credits at the end of the movie. It is coincidental and not accurate. Although no one case is represented here, my patients are asked to sign a consent form which gives me permission to utilize their case material for the advancement of psychology, and they are also allowed to refuse to give such permission, which is and isn't such a big concession. It may sound like I'm being so nice, but so often with traumatized cases, saying no is not the easiest thing, but it's what we have. Further, I informed them that the use of the casework, including their own, may be useful for case consultation, teaching illustrations, and future therapists in the learning and or concepts that might become clearer. Also, they're informed that illustrations as such do not require releasing, personal identity or other personal identifying information about them. And they're further informed that another potential advantage is that the struggles and difficulties of their life might do some good to help future generations of learners and people who suffer. So with this in mind, I will clarify that I have never shared a specific case, and beyond creating hybrid cases that combine many cases to help illustrate these clinical realities while facilitating the process and further take great efforts to prevent any feelings of exposure. Let us now proceed with this hybrid case. So it's kind of interesting because it's sort of this, almost comes from reality of many stories, but almost fictional. So we have to live with that limitation. So let me proceed with the case, and then we'll start our discussion. Bill, I'll call him, is a 32-year-old male who was referred by his priest. Bill had been attending church and his family for the past several months. During this time, when he attended Divine Liturgy, he sat near the back of the church. Although quiet and reserved, when approached for a blessing or when the Holy Cross was presented in various forms, he would let out a loud and terrorizing screech that was horrible for everybody that I could see and was not overwhelming. Screech that was not only overwhelming to parishioners, but even his well-seasoned priest would shake and kind of jump back. It was, very disturbing. So also disturbing is that while passing others lighting candles in the narthex, he would often calmly approach and seemingly out of nowhere approach the praying parishioners and shove them, which sometimes included that intense scream or screech that he would let out that I mentioned just a moment ago. In one instance, he punched someone in the nose as they were lighting their candle. So this was of great concern for this. This aspect of the story is something that needed to be dealt with. Bill was brought to his first therapy appointment by his parents. Given his age, despite some of his reservations of his parents, I wanted to see him first. He studied my office, and his eyes seemed both acutely vigilant but also far away somehow. When I asked him about his life, he said that he was a hopeless case because he was demon-possessed. At times that I could not predict, his face suddenly changed, and he would let out one of those loud shrieks. And this sent me flinching backward in my chair, and I often found myself needing to summon up large amounts of courage as I muttered the prayer of the heart to myself many times over during some sessions. In early sessions, he was unbathed, smelled badly, and his hair and clothing were disheveled. Sometimes he shrieked and produced when he did shriek, he produced a foamy saliva that resembled that of a rabid dog. Not unlike images some people have seen before about this sort of topic. One positive factor seemed to be that he seemed to calm down and feel soothed by my interest in his story and my not being too overwhelmed, and I put this in brackets, relatively speaking. I'm sure he knew I had flinched, while at the same time I still remained engaged in talking with him. So I let him stay and I talked with him. So later I was to learn from his parents that before becoming to the Orthodox Church, they had brought him to several Pentecostal evangelists and healers who prayed for him to have his demons cast out. Many of these so-called healers even offered to do so for sums of hundreds, even thousands of dollars. So I noticed when I asked Bill to recall these prayer meetings and gatherings that he seemed to form kind of a profile of what a demon-possessed person was. And it seemed that he might have attached himself to this narrative. And I wasn't sure, but I just, is this who he is, or is this an evolving script? I don't know. But, I wasn't skeptical, but I filed that away, that observation. So he could maybe that he could explain it to himself or explain it to others, for his behavior. Which included how to explain his despair, his depression, his disjointed state of mind, all apparently leading to his view of himself as demon-possessed. It seemed noteworthy in this regard that he was somewhat self-diagnosing in this way. So after receiving permission to call his priests, he had a few as he traveled from parish to parish, I asked one father if he felt that Bill was demon-possessed. I was somewhat surprised when the father told me that, well, this is possible, but he added, I think there's something more here. That also felt helpful. I felt challenged to move out of my either-or thinking and consider what might have always been in my mind is, well, it's either a spiritual problem or it's an emotional problem, but, a lot of interaction of different things. Kind of an intersection in the minds of some individuals, perhaps all of us, spiritual and emotional. These things are all rolling around. So meanwhile, his parents were taking him to several notable monasteries to have prayers to ward off or cast out evil spirits. This is how they would convey it. He seemed to improve after these meetings and prayers, and I was given permission to call these monastics, but I didn't receive a call back. I did not take this to mean anything per se, but I did wish to learn more about their perspective of Bill. Meanwhile, after he improved from prayers, he continued to have these outbursts, maybe less frequently, and he did need to be hospitalized for psychiatric reasons after becoming suicidal, including voices telling him to kill himself and his family. During his hospital stay, he was prescribed heavy doses of antipsychotic medications, major tranquilizers, which he took for a few weeks, but ceased taking them because of the dead-like, zombie-like behavior that they produced. In sessions, he would become clearer and more lucid, and the number of violent shrieks became less frequent. So in an ongoing way, the severity appeared to decrease. I didn't think necessarily because of the hospitalization, but it appeared to be something was happening because he was settling in a little bit with sessions. At least that's maybe how I like to think about it. Anyway, let's see. So in these sessions, as he became clearer, I was to learn, sadly, that a childlike voice kind of emerged. It seemed like a dissociative state from him. And I was to learn from this childlike voice that a paternal uncle had sodomized Bill repeatedly since he was 6 years old. And he stated that he tried to tell his grandparents and that he was staying with about the incidents, but reportedly they never believed him. Instead, they shamed him and told him if anyone told if he told anyone, his parents would be killed. So although he felt my empathy for him, these parts of him seemed to respond well. An adult part of him seemed to not believe it. He would say that it was like another person told it to him, someone else's story, not his own. And that did seem genuine. It was like someone else almost. It was not my experience, was his words, as well as some other cases that come across this in therapy. Meanwhile, he related that he was having unrelenting nightmares of being chased by invaders from outer space and watching people get killed and other horrors. A second priest called me after Bill gave me permission. The priest was concerned. Let's see. Okay, yeah. I'll make sure. Okay. The priest was concerned about the possibility of demonic influences, but was also curious about his history. When I explained to him that the violent sexual trauma that he had apparently experienced from his early life, or there was a pretty strong possibility of this, the priest became very saddened and disturbed. and became profoundly empathic for Bill. We shared our concerns of how his efforts to improve seemed to get undermined. His parents had seemed to focus on his craziness and their assessment of demonic elements, that there seemed to be a collusion between them and Bill not having anyone know about the trauma. So I wondered if they were more invested in him as being demon-possessed or mentally ill or both. And I thought, no matter how much we want to know the truth, whether some truths were too painful or shameful to bear. Either way, the multiple levels at which one might wonder how this poor soul was traumatized, possessed with the idea of being possessed, or was he possessed? And not only that, but the spiritual cost of his condition seemed immense. Finally, an overlap between deception, intimidation, and shame, between what might be wicked and traumatized forces in his mind, seemed quite daunting. I don't have this in my notes, but it's almost like it was a pause to say, is this part of protecting himself from the trauma, to have a narrative of, all this? Over the next few months, Bill had a lengthier psychiatric hospitalization that interfered with his progressing in treatment with me. Some hospitalizations appeared to arise out of big family conflicts. And so in that regard, I hypothesized, I wonder if we're getting somewhere, and that's what's elucidating both the family's reaction and maybe Bill's fear of it not going very well, and just a big unfortunate mess, further denial, further shame, and further alienation. It's something I haven't talked about so much here, the alienation. This is very profound. So, after his last hospitalization, he did not schedule further sessions. So, here's a summary of what we've gone over. We have his behavior at church, very disturbing, disheveled, depressed, self-condemning. The exorcisms and possible maybe narrative learned there, or I don't know, just that there was just that. It seemed to not be helpful, but it's hard to know. Self-diagnosing himself as demon-possessed, a history of very severe sexual trauma. And remember we talked about how, like, when you have support, it's helpful to come out of trauma and dissociation. Well, hard to heal from such severe trauma with maybe not only no support, but feeling kind of attacked. Family collusion, psychiatric hospitalizations in the context of family conflicts, and partial improvement with prayer and empathy about experience. It's almost like I want to say, I'm sure the prayer was helpful, it's good, but was there also something about the relationship of praying together that was important to him, and another level of why he improved? I don't know that, but we'll leave with that reflection. So we're going to change now and shift. How are we doing on time? Oh, that's...
You about
20
12, 13 minutes before we allow questions.
Okay, well, we're going to turn it to kind of questions now, so we're early.
Perfect.
Yeah, good. So we're going to... Can I have someone move the mic up?
I'll take this one.
Can you speak into the mic up here for the future generations are going to want to hear what you have to pass. So I am opening it up to questions, but I'm also going to have some guided questions for us too. So I'm going to maybe kind of interweave that. But okay, Jonathan.
Thank you. Thank you for the presentation. I may have missed this, but can you comment on some aspect of dissociation where, in terms of modeling for a child or young adult coming up, where there really wasn't either the personality traits or developmental traits that were put forth, so people were kind of grasping towards movies, TV, popular culture as a substitute for their lack of development?
Yeah. Okay, so we're going to, well, I don't know if it's beyond me either, but so, yeah, we're going to also now, as we transition theology, and therapist, and just psychology over here. But so I think, let me make sure I understand your question. Your question is, in certain family contexts, do children receive the modeling of dealing with stressful and overwhelming experiences by focusing away onto cultural things like television and technology and other distractions, I guess? Or
Well, I was sort of responding to this idea of the possibility that there was any kind of like malingering or something going on with demon possession coming from within the patient. But if there were times in his life where he was struggling for an identity, he just grabbed onto one.
Got it. Okay, thank you. Yeah, that's very helpful. Yeah, I think that's kind of the idea that I'm wondering about when I'm thinking about these Pentecostal prayer meetings, and there is. I can't, sort of quantify it, but it seems that we have almost like at certain times a contagion in these ways of many people doing that. But there's a lot of available ways of coping in that way, and dissociating or pushing away the real issue and learning another narrative, another story. I think, I don't want to take us there, but I think we're seeing in this kind of, for the lack of better conceptualization, this gender identity world that there are, there's all kinds of issues there, but it seems to be there might be a subset of that group of people that have other traumas, other difficulties, and they're latching on to that narrative of people that didn't understand them growing up and so on. I don't want to say that's what they all are doing, but I think we're seeing that phenomenon. So can you hold your question? I'm going to move us. Maybe I'll alternate if we have like personal questions and then some of the discussion questions. Please.
To that too.
Thank you, Paul.
I was thinking of too with the because of going back to childhood, like with the family, because it's not really in the case study per se, but if there was a prayer life in the family too, if they were having prayers with him as a child, things of that nature, and see if that wasn't there, that's a possibility as to why there's some of those issues that are developing too. Yeah. If that follows.
Very good. Yeah, thank you. That's a good point. So, in this case of Bill, is there justification for considering both spiritual and emotional problems being at work at the same time in this case? Or do we have to determine whether there's one or the other cause, so to speak? There's no wrong answer to this, but I'd be curious to get your comments or reactions to that. Yeah, good.
So, thank you for this presentation. Over the years, what's been a blessing in my work as a psychologist is developing that relationship with the priest, and also with, in this case here in Chicago, we have a very blessed, active monastery in Wisconsin, within an hour of Chicago, and a lot of Orthodox attend the monastery there, and I have a wonderful relationship with the abbess. And oftentimes, she will send people to me because she feels they need to work on some of the psychological issues. And sometimes I will meet somebody who's not connected to a priest necessarily, but I will be questioning of some of the spiritual elements, and I will ask them to go meet with the abbess at the monastery. Terrific. And we've had this beautiful relationship of being able to kind of say, I'm not sure about this, can you check this out? So I just wanted to share that.
Terrific. And since you're highlighting that, I wondered if you could say anything, the mic again, but or I can hand you mine. It is obviously that we always have as a therapist and priests too, confidentiality. And so some people are just, I trust you, or, whatever. But can you say anything about how you've had to finesse that? Sure. With when you...
So, like with the priests that refer parishioners to me, I will say to my new client, I'll say, well, if you want me to continue to discuss the progress with your priest, I need you to sign a release form. And 80% of them are, yes, absolutely, because we love him. He's our spiritual father. He's working with us. Some of them who are, I'll call it the not so active Christians, who are just kind of like, my wife said we got to go see the priest, and then they're not so active. Well, I'll go talk to a psychologist, but I don't want to talk to the priest anymore, and they don't want. So it's more of where that client is at. Yeah, but and with the abbess, the same thing. I will say, I need your permission, and then she knows as well. I said, so we can collaborate on this situation. Okay. Thank you.
Terrific. Yeah, thank you very much. And maybe some people aren't ready yet.
Right.
Right. So, but okay. Before we go back to the question in the back, any other comments about this? I mean, it's okay if there isn't. We can. There's plenty of other questions we have, but nothing else. Okay. Yeah. So you had a question.
Sure. So
yeah.
I was.
Sorry, you're. Yeah. You have to. This is for history.
That's okay.
Ancient.
I noticed that you cited Donald Kalshed. First of all,
yeah,
that's a great book. Maybe it was The Inner World of Trauma.
That is the one. Yeah.
That is a great book. So, in case you haven't read that, it has a lot to do with dreams too and everything.
Right.
But
right.
I was gonna ask, first of all, when you were in the session where he finally revealed what had happened regarding the uncle, how did that come up? Did you ask the right question, so to speak? Did it just come up organically out of the blue? And then my other question was, what would you have maybe done differently if there was even a chance to do anything differently? I think you did a beautiful job. I was just wondering.
Well, thank you. Yeah, it's, maybe I'm not very methodical. I try to find each person's style of how they're relating to me and how, in a sense, how they want to tell their story. And I didn't have to have any fancy interview techniques or interpretations. He would just sit down and just, when the moment was there, he just riffed, he would just tell me the story. And so my job was to be very present and, obviously empathize with such horrible, experiences. So, I don't know how to say I would do anything different other than because in one way he made it easy, but in another way, what's not easy is to let people say it in their time. I don't mean be quiet for minutes and waste session after session, but a blank screen. I don't mean that, but he seemed to need that. So, yeah, you have a question? You want the, or
me? Yeah.
Yeah, I'm sorry. Oh, this one?
I can use this one, yeah. So I'm currently a psychiatry resident, and I've come across patients like that before where, they really believe they are demon possessed. Mm-hmm. And I guess as an Orthodox Christian, I believe that there is spiritual hosts and that could really happen. And so, she was very treatment resistant in terms of medications and things. And so sometimes I find it difficult to know how to, respond to that kind of thought because I'm well, maybe. And
the demon possession?
Yeah. And so I just wonder what your perspective is in terms of demon possession, if you feel like you've ever really seen that, and how to navigate that as a clinician.
Okay. I will try, and I bet you have some thoughts about that too, maybe, huh? Yeah. Father Paul, yeah, because you've worked with some of the, yeah. So okay, good. I will try. So I think I'm definitely an empiricist, and that doesn't mean that I don't believe things I don't see. It actually means the opposite. If I've never seen it, it remains open to question. So we go, I think, in our minds from one range of, well, is that the language of before modernism, and now we describe what they call demon possession then now, or do we have all this going on? And I think that it probably also depends on what we mean when we say demon possession. That the person is under the control of evil influences, or, are they? There's nothing more dramatic than that scene where Jesus confronts, the legion, and it's like, there's seems to be, if that's a true story, that is proof, right? And so I think we're left to consider that that's a possibility. I think that when it's clinical, as a psychiatrist, psychologist, or other therapists, social workers, and so forth, that it's important for us to not be out ahead of them and let things unfold. And, that worked in this case. It was over time, but meaning not to jump to the gun of overly psychologically interpreting something. I never did that with him, at least in the time I did have with him, and or jump to the conclusions. It's this must be demon possession. I think it's important to just think about how that evil forces, Satan, and so on, exploits weaknesses and vulnerabilities in human beings, and also, those kinds of experiences are very painful and difficult for the person, because it affects how they feel about themselves emotionally. You said one other part of your question that I haven't gotten to that I wanted to say something about. Maybe I'll think about it when I let Father Paul say some things here.
Actually, that kind of brought to mind, it was few months ago, because I had a client that actually thought that he was seeing Jesus all the time, was having conversations with him, and he was very devout Roman Catholic, so it was a little bit easier for me to work with that when talking to him. I would ask him, well, when Jesus is telling you to write letters to people and harassing them and stuff like that, I don't think that's what's going on there. I said, have you thought about making the sign of the cross, or and stuff like that? And he hadn't thought about doing that. I said, well, next time that happens, why don't you make the sign of the cross? Because if it was really Jesus, he'd still be there. And if it was, some demon possession, it would disappear, and you wouldn't be having some of those thoughts. And then I would talk about using the Jesus prayer method, and unfortunately, I never got a chance to finish because one of the doctors that was working with him said that he would hung himself in a closet one night, so I didn't really get. So it's kind of one of those horrible things that he must have been hearing the voices and just took his own life. So that's always a hard thing with that right there.
Yeah. Thanks for sharing that. Bill, in this case, is not like the Hollywood ending. But I still can't remember the part. 5 left. Okay, so I don't know if briefly. This was probably more for Father Paul, and other priests here, perhaps. And ask, what are some ways a priest could support the therapy process while keeping an eye on the spiritual life of protecting their flock, so to speak? They're being attacked in the narthex, and maybe that's a very hard question. But anybody want to try to talk about that aspect? Yeah, good.
Well, I was thinking of it in the same sense with the sexual misconduct stuff that happens sometimes in church, where you try to find an accountability person. And I was just thinking, with him being in the church there, especially sneaking up on people like that, is maybe having another person that he trusts that could kind of be with him. So if he does start to screech or anything like that, can kind of draw him back in so he doesn't do that. And that way you're protecting him and the community members at the same time. So that was one of the things I was thinking of.
Yeah. That sounds really good, and I like that, because there's almost this implicit relational thing going on. Someone's Bill hadn't had that kind of support and someone helping him, I think he would have warmed to that quite well. So that's thank you. Okay, let's see. So, is there other questions before I? Yeah.
Just similarly, I mean, we're talking about supporting and interacting with, in this case, the client or the patient or parishioner. But obviously the family in this case and in many cases is very much involved. And so I would be interested to hear from you all, both from the priest and the therapist side, how and when you engage with the family.
Yeah.
Throwing you a softball.
Yeah, no, it doesn't feel like a softball. However, I do remember with Bill that I would bring in his mother from time to time, and this is a hybrid. Bring in the parent from time to time, and what would be really difficult is in the cases that relates to what this presentation of Bill is the levels of manipulation and kind of passive aggressive behavior was very difficult to engage, and on one hand appear very supportive of the treatment and we're going to follow all that you say and everything, and then undermine it all just next week, like a little kid who says sure daddy, and then they go and do. So do you have further comments about Paul?
Well, I mean, I guess it's because getting to know the family and such, but sometimes just from my years of experience, they don't tell you everything when you go in, and especially home blessing time or when you try to come in and visit. And a lot of times they say, no, I don't want you visiting or anything like that. I've had some people, I've never visited them in my life because they don't want me over at their house. So, and it's probably because there's something going on there, most likely. So,
yeah. However, back to the softball question, it is good to try to get a sense of the family and see what you can do, or if there's some interventions you might be able to do to help. Yeah, Ari. Yeah.
That's one of the things I've noticed is the family is so desperate for support and help, so desperate. They're feeling so lost, and they're just with open ears, like, how do we handle this? How do we take care of our adult child, let's say, who has schizophrenia, but may claim that they are demon possessed? And those are kind of the exceptions when, for me at least, if my client is absolutely diagnosed with schizophrenia, I worry less about confidentiality with the parents because they're not in their right mind. And so I need to be able to give them more direct feedback to say, this is what, for example, one of the best pieces of research came out with families with schizophrenia is the family has to be very calm and quiet. That any agitation aggravates the schizophrenic so much worse and really upturns the family life. So that atmosphere at home is really needing some guidance, and the parents are desperate for that guidance. How do we manage this? And I think that's very helpful and needed.
Yeah, thank you. They're so overstimulated. Yes. The filter, in ego psychology terms, the stimulus barrier is really limited, and they're flooded a lot. So is that the right time? We have like 3 minutes?
Yes.
Okay, good. You might have a question. So let's see. How can the psychotherapist coordinate with the priest or spiritual father to support Bill's progress? Any thoughts about that? This may be a hard question. So, you got to answer this one? Yes. I guess. Good morning. Father Isaac. Thanks. Yeah,
it just, one thing that comes to mind, it's hard to think of a way that I guess both fields could totally get on the same page with regard to everything and have a common understanding. That's asking for too much, probably. But if both camps were able to think about what's a kind of container that serves this person well, and so and some of that boils down to even just purely kind of behavioral elements. So in church, Just to go back to the question of how do you handle a situation where somebody might be shrieking in church, you could draw a bit from what they did in the 4th century was you put them in the narthex, and not not to literally not to take that to the letter, but the idea that there's actually the consideration of how does this work in this space and with what's going on behaviorally. And so if somebody's shrieking in a way where they're impeding the ability of other people to worship, then that needs to be addressed on that behavioral level. And so if both sides were thinking like what's going on in terms of the container this person has in therapy, in their family, in the church setting, and they were able to collaborate on that level, how is this structure and container affecting them? What does it offer in terms of helping them grow to greater awareness and understanding of what safety consists of and all that? Yeah. That might be a fair enough common denominator.
Yeah, terrific. I think that's really helpful. So yeah, we had, yeah.
So what I'm wondering is how, with this bill, right? What brought him to your office if everyone was diagnosing him as demon possessed, how he even ended up at your office? Because I'm thinking that there's some sort of thought process there in terms of communicating the psychotherapist and the faith, the priest, that's happening outside of the office or the church, that's bringing us together. And I'm trying to understand that a little bit better.
Yeah, that's a really good question. The part that feels like needs more thought for me is that part about the priest and the therapist. The way understanding Bill's behavior to me was like, everyone's invested in this, back to family therapy literature, the identified patient, the scapegoat. And I'm thinking of what Father Isaac said, this container is different than that. It sort of provides something different and cohesion and sort of gives them a chance to benefit from containment and care and maybe the proper attention to him instead of the investment into the identified patient role that he's playing. He comes in and maybe he doesn't even really want help. He's just serving out this, like, I'm the bad, evil, person. Okay. All right.
Let's all thank Dr. Harris.
Thank you.